Hi everyone and welcome to our module on Adrenergic Agonist. In this module, we're talking about everything there is to know about Adrenergic Agonist, from the classification of the drugs to various examples, then the mechanism of action of these drugs, the indications or uses of Adrenergic Agonist, adverse effects, and then some contraindications. Adrenergic agonists are drugs that tend to mimic the action of norepinephrine. If you remember from our previous module, norepinephrine is a neurotransmitter involved in the ANS system. It's one of the few neurotransmitters alongside acetylcholine. Norepinephrine tends to perform its action on the autonomic nervous system by acting on adrenergic receptors in the body. And the specific sites where we do find adrenergic receptors in the ANS system is at the effector organ supplied by the sympathetic nervous system. As a result, we tend to say that the adrenergic agonists, because they mimic norepinephrine, they tend to also perform similar actions to the sympathetic nervous system. Therefore, we tend to refer to these drugs as sympathomimetic agents because they mimic the sympathetic nervous system. How do we classify adrenergic agonists? We can classify them based on their activity or inactivity at the receptor site. We have direct acting drugs, that drugs that tend to act that particularly on the receptors, on the adrenergic receptors. And we have indirect acting. These drugs do not act on the receptors, but they, in one way or the other, increase the amount of norepinephrine present at the receptor site. So this norepinephrine would do the action for them. And then we have the mixed acting drugs. These are drugs that have activity at both the receptor site and elsewhere. The direct acting drugs are further divided into alpha and beta agonists. Remember that we have two major types of adrenergic receptors, the alpha receptors and the beta receptors. To further break down the direct acting adrenergic agonists, we have alpha and beta agonists. The alpha agonists are further classified as either selective agonists or non-selective agonists. Remember that alpha adrenergic receptors are of two types, alpha 1 and alpha 2. So we have drugs that could either be selective for alpha 1 or selective for alpha 2. And we have drugs that are non-selective for either of these two receptors. Beta agonists are also classified further into selective and non-selective. You should remember that the beta adrenergic receptors are of three types: alpha, beta 1, beta 2, and beta 3. And as a result, we can have selective drugs for either of these types of beta receptors, or we can have non-selective drugs that we're working on all of those beta receptors. So this is another image that illustrates for us the classification of adrenergic agonists. As you can see, the adrenergic agonists are further classified as either direct acting, mixed acting, or indirect acting. And they're all examples written here to show each of those different classes. We'll be discussing the examples in the next couple of slides. Starting with the direct acting drugs, start with the alpha agonists. The alpha agonists, like I said, are further classified as either non-selective or selective. The selective examples of alpha agonists for the direct acting include epinephrine and norepinephrine. And these are the natural ligand that we see in the body. However, we do find a synthetic form of epinephrine produced and used for treating different conditions, as you can see on the screen below. For the selective alpha agonist, we further classify selective drugs as either alpha 1 selective or alpha 2 selective. Alpha 1 selective drugs include drugs like phenylephrine, midodrine, methoxamine, oxymetazoline, chlorethylclonidine, and metaraminol. These are all examples of alpha 1 selective drugs. And you could see a picture of the drug phenylephrine here as a nasal spray. We'll talk about the uses later on when we get to the indication section of this module. The alpha 2 selective drugs are drugs that include the drug alpha methyl and alongside other drugs that have very similar suffixes. So we have drugs like the clonidine, minoxidine, apraclonidine, brimonidine, and if you notice, each of those drugs tend to have the suffix nidine ending them. So that's one way we can recognize some of the alpha 2 selective drugs. We have some other drugs that don't necessarily follow this particular format. The drugs like guanafacine or guanabens, and then other examples like agmantine and lofexidine. So these are all drugs that will be acting on alpha 2 receptors. We'll talk about the mechanism of action of the alpha 2 receptors very soon. For the beta agonist, non-selective beta agonist includes also epinephrine, norepinephrine with an added added drug of isopreterenol or isoprenaline. And this is just for us to note the fact that aside epinephrine and norepinephrine for beta non-selective drugs, we have an extra drug there. Selective beta agonists are also subclassified as beta 1 selective, beta 2 selective, and beta 3 selective drugs. For beta 1 selective drugs, we have drugs like dobutamine, denopamine, prenaterol, and salmeterol. And these drugs are drugs that will be acting exclusively at the heart. Remember that the heart contains largely beta 1 receptors. Beta 2 selective drugs are more numerous. We have drugs like ritodrine, salmeterol, albuterol, as we can see, is a popular drug used in inhalers, Ventolin inhaler, terbutaline, formoterol, pebuterol, metaproterenol, and then bitalterol. These are all examples of beta 2 selective drugs. What you quickly notice about most of the beta 2 drugs is that they have a similar suffix, the suffix of ROL or ROL. So once you see a drug ending with ROL or ROL, you should be thinking about a beta 2 selective agonist. And finally, we have the beta 3 selective drugs. And beta 3 selective drugs include drugs like mirabegron, solabegron, and amibegron. And you would also notice that there's a unifying suffix that tends to be found in all three of those drugs. And that suffix is the word begron. So when you see begron, you should be thinking about a beta 3 selective direct acting adrenergic agonist. Now, the indirect acting drugs are drugs that tend to act elsewhere aside the receptor site, and there are different types of indirect acting drugs that do different things. The sole aim or the sole goal of the indirect acting drugs is to increase the amount of epinephrine and norepinephrine present at the receptor site. So even though these drugs cannot act by themselves at the receptor site, they would improve or increase the amount of the natural ligand present there. So this natural ligand can now further stimulate the receptor site. So these drugs can be classified into reuptake inhibitors. We talk about examples on that. Monoamine oxidase inhibitors, catechol O methyltransferase inhibitors. Some of these words are very familiar. We talked about them when talking about the biosynthesis of epinephrine and norepinephrine. Now we have the neuronal releasers. Examples of the reuptake inhibitors include cocaine. As you can see on the screen below, here's a picture of the illicit drug cocaine. Then we have other drugs like tricyclic antidepressants and atomoxetine. Tricyclic antidepressants include drugs like amitriptyline, as you can see on the screen. Another example of an indirect acting drug would be the monoamine oxidase inhibitors. And examples of drugs under this group includes phenelnezine, trannyl cyclopromine, and selegiline. And if you look closely, you will see that there's a picture of phenelnezine present down on the screen. For the catechol O methyltransferase inhibitors, we have the two drugs entacapone and tolacapone, and you'll notice the suffix there, the capones there present there to identify these two drugs. Some of these drugs we talk about, the monoamine oxidase inhibitors, tricyclic antidepressants, catechol O methyltransferase, are drugs that would focus on later on in the neuropharmacology model. And the neuronal releases are the last example of the indirect acting drugs. Under this class, we have drugs like amphetamine. Amphetamine is shown or represented in the image below. It's an illicit drug for psychoactive use. We have tyramine alongside methamphetamine. The last class of adrenergic agonists is the mixed acting drugs. Like I said, the mixed acting drugs are drugs that can either act on the receptors or elsewhere. And the common example of the mixed acting drug, the only example of the mixed acting drug, is the drug ephedrine. The mechanism of action of the direct acting and the indirect acting differs. For the direct acting drugs, these are drugs that will bind on the receptor site and stimulate the receptors, being agonists. Doing so, they would lead to the activation of the G protein um, cascade of the G protein coupled receptors that they are binding at. And this can either lead to the increase or the decrease in the production of secondary messengers, which would eventually lead to the activation or inactivation of different enzymes. If you remember from the previous model, the alpha and beta receptors tend to be classified as metabotropic or G protein coupled receptors. The difference between these two receptors is the fact that each of the subtypes tend to make use of different G protein and different G protein cascades to perform its action. For example, the stimulation of alpha 1 receptors by selective or non-selective alpha drugs will lead to the activation of GQ, and GQ will lead to the increase in the secondary messengers IP3 and DHE, and this would eventually lead to the activation of protein kinase C and the increase in calcium levels. For alpha 2 receptors tend to work with the G protein GI, and this tends to reduce the secondary messenger cyclic AMP. Reduction in this secondary messenger will lead to the inactivation of the enzyme protein kinase A. And finally, all beta receptors makes use of the similar G protein GS. GS tend to activate at the new cyclase that would increase the secondary messenger cyclic AMP. Increase in cyclic AMP will lead to the activation of the enzyme protein kinase A, and this is how the beta receptors tend to perform their actions. This image represents what we talked about in the previous slide. As you can see, alpha receptors make use of GQ, alpha 2 receptor makes use of GI, the beta 1, beta 2, beta 3 receptors all make use of GS. Going on to talk about the mechanism of action of our indirect acting drugs, starting with the reuptake inhibitors. These drugs do not act particularly on the receptors. What they tend to do is that they tend to prevent the reuptake of norepinephrine at the synaptic space. Remember that for norepinephrine for the action of norepinephrine to be terminated, it needs to first of all be taken back up either by neurons or by extraneuronal tissues. If it's taken up by neuron, we call that reuptake 1. If it's taken up by extraneuronal tissues, we call that reuptake 2. Either ways, this reuptake process requires the use of transporters. And one way to prevent the reuptake and therefore the metabolism of norepinephrine is by the use of reuptake inhibitors. Reuptake inhibitors will block those transporters and prevent norepinephrine from entering back into the neuron or the extraneuronal tissue. Thereby, this increases the amount of norepinephrine present at the synaptic space, and therefore this can increase the activity at those receptor sites. The second indirect acting drug is the monoamine oxidase inhibitors. Remember, monoamine oxidase is one of the enzymes responsible for the breakdown of norepinephrine and epinephrine. Monoamine oxidase is involved in the breakdown of norepinephrine that has been taken back into the neuron. So one way in which we can prevent the breakdown of norepinephrine and thereby increase the accumulation at the synaptic space is by reducing the metabolism. So drugs like monoamine oxidase inhibitors would bind on the enzyme monoamine oxidase, block the enzyme within the neuron, and prevent further breakdown of norepinephrine, thereby increasing its amount at the receptor site. The second enzyme responsible for the breakdown of norepinephrine is catechol O-methyltransferase. This enzyme tends to break down norepinephrine at extraneuronal tissues like the liver. One way we can increase or augment the effect of norepinephrine without acting on the receptors is the use of catechol O-methyltransferase inhibitors. These drugs bind on the enzyme, inhibit the enzyme, and prevent the further breakdown of norepinephrine. This would improve or increase the amount of norepinephrine present at the synaptic space, and therefore increasing the activity of norepinephrine at the receptor site. And finally, we have the neuronal releasers. Neuronal releasers tend to act at the presynaptic neurons. They increase the release phase of norepinephrine directly from the vesicles. So instead of having to allow for action potential to run down the axon terminal and calcium gated channels to enter and thereby exocytosis occurring, these neuronal releasers bypass those steps and just allow for the release of neurons within the axon freely into the synaptic space. This image depicts for us some of the drugs we already talked about. As you can see, this would be drugs that tend to block the reuptake of norepinephrine into the presynaptic neuron. So these are reuptake inhibitors here. You can see drugs like imipramine, fluoxetine. They are all examples of the reuptake inhibitors. And then we have the drugs that tend to block monoamine oxidase. You can see the monoamine oxidase inhibitors present here. So they will be blocking this particular step of breakdown of norepinephrine by monoamine oxidase within the neuron. So this is another picture illustrating for us the mechanism of action of some of the indirect acting drugs like the catechol O-methyltransferase inhibitors and the monoamine oxidase inhibitors. You can see them blocking the breakdown of some of the catecholamines like dopamine Although what we are meant to talk about is the breakdown of norepinephrine, not necessarily dopamine, but dopamine is a catecholamine that could also be broken down by these different enzymes. So one way we can prevent the breakdown of our catecholamines would be by the use of drugs like COMT inhibitors and monoamine oxidase inhibitors, as shown in the picture. Finally, we have the mixed acting drugs. Mixed acting drugs, particularly ephedrine, tends to work by acting on both alpha and beta receptors alongside being a neuronal releaser itself. So it acts as a neuronal releaser on the side, but its main action is on the receptor. So it's both direct acting and indirect acting at the same time. Hence the reason why we call it a mixed acting drug. This drug is very, very powerful because of its dual activity. As a result, we don't necessarily tend to give it so much because of side effects we tend to see due to its dual activity and those different mechanism of action. This is the drug ephedrine. This picture illustrates the action. You can see ephedrine working on alpha and beta receptors at the postsynaptic neuron, and you can also see ephedrine leading to the further release of norepinephrine from the synaptic presynaptic neuron. So it acts as a neuronal releaser. That's its indirect action, and it also acts on the receptor. That's its direct action. Hence the reason why it is a mixed acting drug. What are the uses of direct acting and indirect acting adrenergic agonists? Starting with the direct acting drugs. Direct acting drugs could be used for treating bronchial asthma. Typically, we tend to use the beta 2 agonists for treating asthma. So drugs like albuterol, as you saw before, are part of anti-asthmatics are used in treating asthma. This is because we find beta 2 receptors largely within the lungs, and as a result, stimulation of those receptors will lead to bronchial dilation. We could also use them in treating COPD, which is kind of very similar to asthma. And we also make use of beta 2 receptors in treating this particular condition. Nasal congestion could also be used, could also be treated with direct acting beta and alpha agonists. In particular, we use drugs like phenylephrine, which is an alpha 1 agonist in treating nasal congestion. Hypertension could be treated with the use of alpha 2 agonists, specifically alpha 2 agonists. So this is important to note. We don't treat hypertension with any other adrenergic agonist aside the alpha 2 agonists like alpha methyl clonidine, and monoxidine. Every other drug that we classify as an adrenergic agonist, on the other hand, can be used in treating hypotension. So the exception to this rule is the alpha 2 agonist, which is used in treating hypertension. Other direct acting drugs indication includes cardiogenic shock and anaphylactic shock. Anaphylactic shock, we prefer to use epinephrine in treating this. Epinephrine is the drug of choice for anaphylactic shock. So please do note this. Other uses or indications for direct acting drugs include cardiac arrest, acute heart failure, and overactive bladder syndrome. And most of these drugs we are going to be making use of the beta 1 drugs. Remember, the beta 1 drugs are drugs that are typically cardiotonic. They tend to work on the heart. So cardiac arrest and acute heart failure, we prefer using beta 1 drugs in treating them. For the overactive bladder syndrome, we make use of either the alpha 1 or the beta 2 drugs in the treatment of this particular condition. And this is a picture of a person with asthma making use of an inhaler. The inhaler contains the substance salbutamol. Salbutamol is a beta 2 agonist. And you can see what salbutamol does to the lungs once it has been inhaled. In a typical asthma patient, this is how the lungs will be closed off. This is how the respiratory tract will be closed off. The use of the beta 2 agonist, as you can see, will lead to dilation of the bronchioles, and that will ease or relieve the symptoms the person is having. This is an image of a patient receiving a shot of epinephrine for anaphylactic reaction. So whenever someone is having an allergic reaction or anaphylactic reaction, the fastest way to treat it is by giving the drug epinephrine. Epinephrine is the drug of choice for anaphylactic shock. For indirect acting drugs, the indications include conditions like depression. Depression can be treated with a number of indirect acting drugs like the reuptake inhibitors, so drugs like the tricyclic antidepressants. We also can use the monoamine oxidase inhibitors in treating depression as well. So these are the two examples of indirect acting drugs we use in treating depression. Anxiety disorders could also be treated using tricyclic antidepressants. So these are reuptake inhibitors. Post-traumatic stress disorder could also be treated with monoamine oxidase inhibitors and tricyclic antidepressants. Same with obsessive compulsive disorders. Parkinson's disease is treated using monoamine oxidase inhibitors alongside called methyltransferase inhibitors, right? Particularly the type of drugs that tend to work on dopamine, as you saw in that particular image that showed the breakdown of dopamine and the inhibition of this breakdown using the COMT inhibitors and ammonium oxidase inhibitors. So these guys using treating Parkinson's disease. And then finally, attention deficit hyperactivity disorder could also be treated with drugs like amphetamine, methamphetamines. These are drugs that tend to either increase the attention span and reduce hyperactivity of children or people that have been diagnosed with this condition. For the mixed acting drug, which ephedrine is the only example under that, the uses of this drug includes nasal congestion, hypotension, narcolepsy, and myasthenia gravis. Although we don't really prescribe these drugs, we have some other first-line drugs we prefer to use for this set of conditions, and that's because of the fact that ephedrine, because of its dual activity at those different sites, tend to have a very very toxic effect, and as a result, we prefer not to use it at all. What are the adverse effects of adrenergic agonist? So these are the adverse effects of adrenergic agonist in terms of the fact that once it has been used in excess, it would overstimulate the sympathetic nervous system and then cause this set of side effects. The first side effect is hypertension. So most of our adrenergic agonists will lead to hypertension. Right. The only exception there is the alpha 2 agonist. Alpha 2 agonists tend to lead to hypotension, not hypertension. So you can say alpha 2 agonist is kind of a sympatholytic agent. Although it is classified as a sympathetic agonist, at the end of the day, the effect tends to be sympatholytic. It tends to reduce the activity of the sympathetic nervous system. This is because alpha 2 receptors, like I said in the previous model, is found on the presynaptic neuron. And the job of alpha 2 receptors on the presynaptic neuron is to reduce further release of norepinephrine. So imagine if alpha 2 receptors are stimulated. It means that not all the norepinephrine released at the sympathetic nervous system and at different organ sites supplied by the sympathetic nervous system would be reduced, would be shut down. And as a result, we have a reduction in the activity of the sympathetic nervous system from there. So we see hypotension in drugs that are alpha 2 agonists. We also see sedation as a side effect of alpha 2 agonists because it is reducing the sympathetic nervous system, not increasing it. Other side effects that we see for other adrenergic agonists includes tachycardia. This is seen in beta 1 receptors in the heart, palpitations, tremor, anxiety, and dry mouth are all side effects that we see for the sympathetic nervous system excess once it has been stimulated by other adrenergic receptors. So what are conditions in which we do not give adrenergic agonist for? So conditions like arrhythmias. Arrhythmias will be worsened if we give people adrenergic agonist. We treat arrhythmias with adrenergic antagonists rather than agonists. Diabetes mellitus could also be a contraindication. This is because beta 1 receptors are found in the liver, and stimulation of beta 1 receptors in the liver leads to hyperglycemia as a result of the activation of the glycogenolysis pathway and gluconeogenesis pathway. So, giving somebody a beta agonist would stimulate further increase in the glucose level in the blood, and this will worsen diabetes. Hypokalemia is also a contraindication because of the fact that if someone is already having hypokalemia, the person is at risk of arrhythmias. So giving them a beta agonist would further worsen the chances of them having arrhythmias because the hypokalemia is already a trigger for arrhythmias. Chronic heart failure, myocardial infarction, hyperthyroidism, hypertension, and benign prostatic hyperplasia, they are all structures or they are all conditions that tend to present with um, either increase sympathetic activity or there are conditions in which the use of beta agonists would worsen these symptoms. So conditions like chronic heart failure, if you use a beta agonist, this would worsen the condition because the person will be tipped into what they call a decompensated heart failure, and that's usually the worst form of heart failure the person would have. Same thing with myocardial infarction. Hyperthyroidism and hypertension is already an increase in sympathetic nervous system. So giving people these drugs will worsen the side effects of this particular, the worsen the symptoms of this particular conditions. And benign prostatic hyperplasia would also get worse with the use of epinephrine and norepinephrine or drugs that tend to mimic their action. And that concludes our model on adrenergic agonist.